I will speak about the evolution of hepatic surgery. Indeed, liver surgery is not old. For me, it is around 25 years, not more. And I will show you that today, it is one of the part of surgery who are in evolution. If we look at Annals of Surgery, which is, as you know, the best journal of surgery, today, the first topic of publication is hepatobiliary, including liver transplantation. That means that this is in development. Now, if we go in the past, this is very, very in the past, only to let you know that the first successful elective liver transplantation, before it was some case of trauma, of course, packing, very rough, of course, technique. But the first elective was performed by the great German surgeon, Karl Logenbuch. He was the one who did the first cholecystectomy in 1882. And he did the first liver resection. But indeed, the patient recovered. But if we look at the specimen, it was normal tissue. That means the first case was not a good indication, indeed. Now, I will go to what I call now the history, the prehistory. There is a date. The date is the 50s. And very interestingly, in the 50s, there were, in the United States, publication of a short series of liver resection by Quattelbaum. He published some case, but with success. But it was not, I will say, a very well-defined technique. However, in France, there was this publication by Lorta Jacob on the first, and really it was the first, right liver resection, anatomical liver resection. By clamping the vessel, it was really anatomical liver resection. In the same period, always in the 50s, and this is a great moment, was the publication by the French surgeon. It was mainly anatomist more than surgeon, Claude Quinault. And I think you know, he published a book called The Liver, Anatomical Study and Surgical Study. It's a heavy book, 500 pages. I tell you, you cannot read it. Even me, I never succeed to read completely this book, for it is very complicated. Yeah, but what he showed, by studying casts, he was the first to do casts, and he showed the repartition of the portal blood inside the liver. And this is the basis, what I say, of the modern anatomy, what is called the functional anatomy of the liver. And you know what he showed is, well, that according to the distribution of the portal blood, there are 4 parts of the liver, and the 4 parts are divided by the hepatic vein. So this is the concept of the functional liver. Of course, if we put that on the true liver here, we find this Quinault called segment. That means the liver is made by 8 segments here. He put number, and the number are put in this way, you know, the central one, which is a small autonomous liver is segment 1, you see, behind, just in front of the vena cava. And then, clockwise, he put number, 1, 2, 3, 4, this is the left liver, and the right, 5, 6, 7, 8. Okay. But we were in the 50s, and in the 50s, there was no means to look at the liver, to find tumor of the liver, for instance. That means that we were waiting the clinical symptom, and you know when there are symptoms in liver disease, it's too late to do surgery. That means we have a huge tumor, and of course, all the segmental anatomy was not usable in this kind of liver tumor. That means that we have to wait the early 80s to have the first investigation, preclinical investigation of the liver, which is ultrasound. So ultrasound is the first tool that allowed the clinician to find small tumor, like this one, 2-3 centimeter tumor, of course, asymptomatic. And it is only at that time that starts the segmental surgery of the liver. And this is, for me, really the beginning of the modern liver surgery. At that moment, it was in 1982, I published this paper, which was a little provocative. It was in an international journal. It was mainly for the American surgeon. And the title was provocative, for I put surgical anatomy and anatomical surgery of the liver. In addition, in this paper, I said, in the sentence down, that time is finished when we do atypical liver resection, and we must really now do anatomical liver resection. Why? By passing for the resection in the anatomical line of division, you find a bloodless line of resection. And in the same journal, I said that it is possible to do segmentectomy. Each segment may be removed independently. Of course, we may associate segment, do B-segmentectomy, 3-segmentectomy, half liver resection. That means from the segmental anatomy, you may do any kind of liver resection. This is the first pillar. Really, anatomy is mandatory to do liver surgery and is the first pillar of liver surgery. The second pillar came very shortly after. For in 1984, the Japanese start first, we start doing intraoperative ultrasound. And intraoperative ultrasound allows the surgeon to look inside the liver and to look what? To look the vessel, but the vessel are the line of division. That means by this example of what I call the transparent liver, the intraoperative ultrasound allows the surgeon to study the real liver of the patient. It is not the application on the liver of the patient of the anatomy of the book. It is the own anatomy of the patient, the liver you are doing surgery on. And by finding the line of division, in addition, by putting on this liver the place of the tumor, you may know where is the part of the liver with the tumor, where about the relationship of the tumor with the vessel, and you may decide exactly what kind of surgery you must do. This is what I call hepatectomy à la carte. That means you order the type of liver resection that is needed for the patient. And really, it is the second pillar. It is, I think, the introduction of intraoperative ultrasound for liver surgery has the same impact that many years ago, the introduction of intraoperative cholangiography in biliary surgery. That means it's really a big change. Now, when we start doing that, of course, the first concept of liver surgery is based on the vessel. That means that the concept is vessel, the liver is vessel surrounded by parenchyma. That means to go inside, you have to go to the vessel. How to go to the vessel? It is to remove the parenchyma. This is why when we start, we have to separate the parenchyma in direction of the vessel in order to find the vessel, to ligate the vessel. The first way to do that was digitoclasy by the Taiwanese surgeon called Lin. I adapt digitoclasy, it was with the finger. I say finger, very rough. And I prefer to use a small clamp, the Kelly clamp, and I introduce the Kelly Clazy. And then more modern is ultrasonic dissector. The CUSA first, and then there are many ultrasonic dissectors. But all this machine have the same objective, is to remove the parenchyma in order to find the vessel. Of course, we need to control the bleeding before. For we are not doing by this, we are not controlling the bleeding. We need to control the bleeding outside of the liver by clamping the vessel at different level. The first one, the lower one, is the Pringle maneuver. That means clamping all the hepatic pedicle. But we may be more selective, and on this drawing, I show you all the level of controlling the vessel going inside the liver, which is what I call the inflow of the liver, the inflow of blood of the liver. And of course, I think in the majority of cases, it is enough to do that. But second concept came after. And the second concept is, which is the real one, this liver is parenchyma with vessel inside. That means objective liver section is parenchyma. But to do that, we need to have new tool. And this concept developed in the second step when we have the tool doing hemostasis at the same time that cutting the parenchyma. And I put the new tools. Some are gadget, I will say. Laser, I don't like at all. Ligature is too small. Tissue link is good. Radiofrequency, and you have the linear radiofrequency, the Habib Seller, and the stapler, which is indeed, I don't like at all. It is a very rough technique. Anyway, we have, with this tool, we have the possibility, without clamping the vessel, is to decide which kind of resection we do, and then slowly we open the parenchyma, doing at the same time hemostasis, that means bleeding is controlled at that time, going to the same line. Of course, it will not change, I will say, the strategy of the operation. Only you change the methodology of doing the resection. That means today we have two types of liver resection according to the strategy you decide to use. Now, to clamp the portal inflow, it's enough for the majority of the liver resection. However, you say on this scheme, if the tumor is highly located, and you see, when you go up to the liver, you arrive to the large hepatic vein. At that time, even small tumor, 3 centimeters, if it is very at the upper part of the liver, is in contact with the hepatic vein, with 1, 2, sometimes with the 3 hepatic veins. At that time, it is not enough to do only the control of the inflow. You need to do more. You need to control the outflow. And how to do that? You may control the outflow only by clamping the hepatic vein. One, or all of them, that means 2 for the middle and the left are in the same trunk. By doing that, you control the outflow, and you may, even if a small tumor is attaching to a vein, you may remove a part of the vein. You have, of course, the outflow clamp, the inflow clamp and the outflow clamp. But if the tumor is larger, and if the tumor is in contact to the vena cava, you need to do more. And this technique, called the total vascular isolation of the liver, was described by an American surgeon. And the principle is, after a total liberation of the liver, to clamp, of course, the portal inflow by clamping the hepatic pedicle, plus the vena cava below the liver and the vena cava above the liver here. This is one technique, but sometimes we need more. When, for instance, like in this case, even the only remaining hepatic vein is touched by the tumor. At that time, you need to do reconstruction of the vein, and you need more. That the first technique I show you, which allow you to have, with security, 1 hour of total ischemia of the liver. We need more. At that time, what to do? I show you, but I think this is anecdotal, 2 techniques. One described by the German surgeon, Rudolf Pickelmeier. That means to do like liver transplantation. You remove the liver totally, like for liver transplantation. You do the surgery on the back table, on the cool liver, and then you replace this in the patient. the French surgeon Laurent Anoun modified this technique, and he said why to cut the hepatic pedicle is better to do the same but not cutting the hepatic pedicle, which avoid to do a difficult step of the operation, and only to do the same but in situ, not ex situ. I think that using this technique described by Fortner, that means the total vascular isolation of the liver, plus the cooling, plus the bypass, you may have 8 hours of total ischemia of the liver, and you may perform what you want in the liver. You may not only remove 1 or 2 parts of the liver, but also repair the portal branch, the hepatic vein inside the liver. And this is, I think, a nice technique. Of course, it is what I call extreme liver surgery. I show you an example here. You see this small tumor. This is a case of Paul Brousse, my hospital. You see the small tumor, which is very badly located just in front of the tree vein in the vena cava. We have to remove the vena cava, and in addition, to re-implant the only remaining hepatic vein in the graft, in the prosthesis, in order to have a good drainage of the liver. So I start by the segmentectomy, which is the smaller part of the liver, anatomical segment, to the large and the very large liver resection. We may remove no more than 6 segments at the same time. You see here we have 2 segments remaining, segment 2 and 3, the left lobe here. This is the maximum we may do at the same time. Now, what is the objective? The objective is to control the mortality. I show you this slide where you show that, first, the main indication today of liver surgery is liver metastasis, and most of them are colorectal liver metastasis. You see? And this is operative mortality and perioperative mortality together. There are 2 more. And you see that more than 50% of all indications of liver resection are liver metastasis. Now, for the mortality, apart 2 indications, which is trauma and hepatocellular carcinoma in cirrhotic liver, and this is special circumstance, apart these 2, where mortality is high, all the other has a total mortality of 1.6% on 2,000 cases. This is, I would say, good, and I consider today that in expert team of liver surgery, this is the mortality we may achieve. It is below 2%, but some series are better. And I show you here, if you see in this column, operative mortality, we have some series with 0% operative mortality. And this is, of course, a perfect achievement. That means it is possible now in the modern liver surgery to achieve 0% mortality. It's a dream. For when I start, in the 80s, mortality was 50%, and you see the progress we achieve. Now, what I would like to tell you is that at the beginning, liver surgery was born in general surgery, and we use nothing more than the tool of the general surgery. But with time and slowly, we have more and more tool, machine, ultrasound. Of course, I spoke about ultrasonic dissector, also argon coagulator, cryotherapy, radiofrequency, and I show you extracorporeal circulation. That means that today, by the technology, we are more and more specialized. Some specialty, like cardiac surgery, was born immediately as a specialty for the technology. Of course, it is not possible to do cardiac surgery without all the equipment of the cardiac surgery. So cardiac surgery is immediately a specialty. It was not the case for liver surgery. But today, with the technology, not only the hardware, but also the software, that means all the knowledge needed, it is a real specialty. I will come on this point later, but one step forward specialty is also liver transplantation. I would like to stop on this point, for this is, I think, important point. Liver transplantation, when it was born, was not liver surgery. And I remind you that the pioneer of liver transplantation Tom Starzl, Roy Kahn, Rudolf Pickelmeyer were transplant surgeons. They were kidney transplant. Tom Starzl was a kidney transplant. And then from the kidney transplant, he went to the liver transplant. But he was not a liver surgeon. The same for Roy Kahn and Rudolf Pickelmeyer. And indeed, when you do orthotopic liver transplantation, you remove the liver totally, and it is vascular surgery. I said it is surface liver surgery. But when liver surgery starts, the true liver surgery, I will come to one, it's my personal experience, and two, it is anecdotal. It is, I think, the first case, and I show you the case. It was in the, 78, and I received in my hospital a patient with really a very severe condition. It was end-stage liver cirrhotic. You see here all the data, coma, massive ascites, albumin was 1.8, renal insufficiency. He was dying. What to do to this patient? He was proposed. They say, can you salvage him? I said, the only solution is to do liver transplantation. And I put him on the waiting list in France, and we find a donor. But the donor was a child. It's very rare to have a child donor, but it was a child. Okay, I accept. I send my team, and when they arrive back in the operating theater, I already start to do the operation. At that time, we don't have the UW solution, but only the Collins, and we are very quick. So the patient already all dissected, and when I saw the liver was 500 grams, very small liver. The patient was 80 kilo, and it is impossible to put this liver in the patient. I changed the technique, and I did an heterotopic liver transplantation. It was not the first case. It was performed already. I put below the liver, letting the liver in situ, and miracle, the patient survived. When I published the case, I said, look, it is a good technique to do that. For you avoid to do all the dissection liver. At that time, mortality was more than 50% in this kind of patient, and it is a good technique. But how to find the child liver? Child liver is very difficult. And I said, in the paper I published in the Lancet, I said, look here, I said that, but you may reduce the size of the liver. Why not? By doing a liver resection on the graft. In order to reduce the size, and I call this technique size reducing the graft. And this is the technique I use on the back table to do a liver resection. I was a liver surgeon. I never did a kidney transplant. So I arrived to liver transplantation from the liver, and it was for me very easy. I was doing liver resection, to do liver resection on the graft in order to have this small liver. I started doing this kind of heterotopic liver transplantation. Then one day, a child came to me and asked me for, this is true, he asked me, I want to do a liver transplantation. I want to have a liver transplantation. It was a bilar disease. He was yellow, he was very small, and he was 11 years, and he said, look, I am very, my life is terrible. The night, I cannot sleep for I have itching, and the day at school, all my friends laugh at me. Please, I need to have a liver transplant. I say, yes, okay, I will do a liver transplantation. But no child liver. And then I say, why not to use in the child to do the reverse? And to put in the child a reduced size liver. And I start doing that on this patient and then on the other. And for instance, this is what is the achievement. This is the child liver that just removed. And this is the graft here, a large graft. But you see, by doing a liver resection, we may have the same size of the graft, that the child graft. And I started doing this, and when 2 years after I published the paper, it happened that it was vulgarized, and at that time, more than 50% of children were dying on the waiting list, and this, with technique, very quickly, all over the world, no child died on the waiting list. So really, this was a simple technique, and it changed. Of course, I use that also in emergency situation for fulminant hepatitis here. And this I put on the slide. In the middle, the heterotopic liver transplantation, the child liver transplantation, and here is the fulminant hepatitis. It is the reduced size. But by doing this, you use one graft for one patient. And with time, as you know, we arrived to a short adult graft, and it was a pity to do that, indeed. And one day, in the same circumstance, I was in the position to do more. This day, it was the 1st of May, a very difficult day in France. It was, as you know, nobody worked. And I received a patient with fulminant hepatitis. Very severe, waiting list, emergency. We have the priority in France, no liver. Okay, we go to Europe, and fortunately, we found in Switzerland a liver. I send my team, and they call me, the donor is huge. He is more than 100 kilo. The liver is more than 2 kilo, and the patient was small. I say, no problem, I will do a reduced size. But 2 hours after, a second patient, fulminant hepatitis, arrived in my unit, very severe too. And I was, at that time, in the position to do this kind of reduced size, to take only one part liver and to throw the other one when another patient was waiting. So why not to split in two the liver and to do like the Solomon judgment, you know, to satisfy the two, to cut in two the liver, easier than the child. And of course, I was prepared to do that, and I did that. And it was the first case in 2 adults. Indeed, without knowing that, Rudolf Pickemeier, 2 months before, did the same for 1 adult and 1 child. It was elective. This was with the emergency. And I split, and of course, this technique was very popular, become the split liver. And in the paper, when I published the case, I said that if it is possible to have 2 patients living with 1 liver, we may imagine that 1 patient is a donor. And at that time, we may have a living donor transplantation. Indeed, the year after, Silvano Raya in Sao Paulo did the first living, as you know, the first living donor transplantation. So it is, I would say, the line of evolution of liver surgery in liver transplantation. For living donor, of course, is liver surgery associated to liver transplantation. I show this case to show you that even in countries where we are not a lot, but we have access to cadaveric transplantation, we have indication. This is a very young girl, 17, and she arrived with this hepatocellular carcinoma. Alpha-fetoprotein was more than 100,000, so it was sure that it was hepatocellular carcinoma. We don't need biopsy. And this is a very severe condition. Of course, we may have performed chemoembolization, but you see, one small part of the tumor was inside the left lobe. The best was to perform. It is a normal liver. It's not a cirrhotic liver. And we have a program of liver transplantation in normal liver for every hepatocellular carcinoma. Why not to do transplant? But we have no possibility to put the patient in emergency. It was emergency situation. She was fiancée. Don't know what is fiancée. You know, pre-married, you know, with a boy, 21 years. And the boy came and said, I would like to give my liver to my fiancée. And so why not? And okay, but in France, the rule and the law is very strict. Only married may give. So I said, no, I cannot accept. You need to be married. He said, no problem. They married, and 3 days after the marriage, they were operated. And So this is the picture. It was 2 weeks after the transplant. You see there is the perfusion line here, and he's the young husband, and he has the hepatectomy. And she had the transplant. So this is the marriage of liver resection and liver transplantation. Yeah. And I may tell you that now we are 8 years, and she's alive, and they have 2 children. Now, I speak a little about the future. This is interrogative mark. For in many meetings, there is a lot of enthusiasm about laparoscopic surgery. So, laparoscopic surgery of the liver. So my question is, it is only abdominal approach or technical improvement? Of course, if you say to the patient, what do you prefer? You open widely the abdomen, or we do that? Of course, he will prefer to have 3 small incisions. But if we look at the reality, there are indeed, you know, of course, it could be today 1,000, 2,000 cases of liver resection by laparoscopy. But it's nothing compared to the huge amount of liver resection performed. I think that it is possible to do it. That means the feasibility is okay. There is no problem with feasibility. But it is needed to do it. This is a real question here. And, of course, we may go to notes for liver resection. We may go surely to the robot for liver resection. But I think this is not the problem. I am sure surgeon will do it. As surgeon may do, not surgeon, sorry, kind of acrobat may do that. But, you know, who may do that? Some will do, but I may say, personally, I don't want to do that. More important, I think, is to improve not only the liver resection, but to improve the way we are doing liver resection and to improve the number of patients we offer liver resection. This is important. For instance, you know that unfortunately today, for any kind of liver tumor, the only way to achieve cure is to offer the patient the chance of a liver resection. And we work since more than 10 years on how to enlarge the number of patients we may offer liver resection. One answer is to change the tumor. The second one is to change the liver. To change the tumor, we start by this paper, and I put also a provocative name, title, Resection of Non-Resectable. I present this work at the American Surgical Association meeting, and of course, it developed after that. There was no oncology at that time, no chemotherapy in colorectal, but after that, as you know, there is a lot of work on chemotherapy. The objective, and I would like to stress, is only to decrease the size of the tumor. You see here there are 4 tumors in the same patient, and after chemotherapy, you see these 2 tumors became these 2, these 2 tumors became these 2, and of course, this is very difficult to do liver surgery, radical liver surgery, and here it is easy. That means only by reducing the size of the tumor, we may change the resecability of this tumor. And we may achieve this, as you know, now this is very popular, very exciting, the association of chemotherapy and colorectal liver metastasis. On the second hand, we need to change the volume of the parenchyma. For instance, here, we have this patient, very large tumor, you see. The resection we have to perform is right liver plus 4 and 1. That means to remove a large, more than 80% of the liver, but we have to calculate. And here, on the CT scale, we found that we may let 30%. 30% is enough. But if we know that the patient had a lot of chemotherapy before, the liver is no more normal. And if we look at the function of the liver, it is not normal. It is half of the functionality of the liver. That means it is not 30% that we let, it is 15%. It is not enough to do with security a large liver resection. At that time, what we do, you know that, we do a portal vein embolization. With glue, we block half of the liver in order to change the liver. And you see there is an atrophy of the right part and hypertrophy of the left part. That means in order to increase the number of liver resection and offer this technique to more patients in order to offer the possibility of cure, we change the tumor and we change the liver. And I think this is the way we are working now, and I tell you, for me, it is more important than doing anecdotally laparoscopic liver resection. But it is a good technique. I don't condemn. I say, yes, there are some indication, and we have some benefit to do laparoscopic, but it's only for some cases. Now, I would like to conclude. First, liver surgery is a new specialty. It is sure. It is indeed one of the three branches of GI surgery. There are upper GI, colorectal, and the third one is the gland, that means hepatobiliopancreatic, HPB surgery. It is not a small specialty. The field is very large. Not only open liver surgery, but laparoscopic surgery, endoscopic surgery, percutaneous surgery, which is called minimal access surgery here. I show you that there is interpenetration between the two branches, liver surgery, liver resection. You see, and I show you external bypass cooling in liver resection. On the opposite, liver surgery by reduced size split. And today, the living donor, which is liver resection in the field of liver transplantation. The new liver surgeon, it is not a simple task for him. He has to be expert, I show you, in anatomy, in echography, in vascular surgery, microsurgery for the living donor, immunology, hepatology, of course. We need to know the disease, and oncology for the vast majority of our cases are tumor. I think that we have to go further. And the new development are multidisciplinarity. And I think that we have to do a global care of the patient by putting all the liver specialists around the patient. The hepatologist, of course, the surgeon, the oncologist, the endoscopist, the radiologist, pathologist, and the researcher. And in order to achieve this aim, I was lucky 15 years ago to build a center near Paris, which is called the Hepatobiliary Center, where all these teams are working together, patient, teaching, research, all together. And I think this is the way we have to do in modern medicine. I thank you very much for your attention.